form, sort of like a little publication. So do have a look at it, edit it. It's just like a basic question answer thing, and we publish that separately.
Will do.
And we will mute for a second because we're already on live, and we'll unmute when we start our introduction for this podcast.
Thank you, Jeremy. Hello and welcome everyone to Khan Clinics. Today we're diving into two very important aspects of healthcare issues that touches almost everyone. One, end of life issues. The other, palliative medicine. End of life issues encompasses those challenges and those decisions made by individuals or family as they approach the end of life for their loved one. These include navigating complex decisions about the care they prefer for their loved one. What are the physical and emotional symptoms that need to be addressed? And how deeply the journey and personal injury that involves something requiring planning, requiring compassionate support, and a lot of support from the rest and the healthcare providers. The second topic which we're going to touch on is palliative medicine, something that really has changed the landscape of healthcare medicine in the United States. Not only does it focus on symptoms and stress that is associated with serious illness for your loved one, but the aim is to enhance that quality of life for the patient, and not only the patient, but the families as well. It's more than just taking care of those physical symptoms, but we have to address the emotional, social, and importantly, the spiritual needs that goes along treating as a standalone approach. Together, these areas form a comprehensive approach to care, to patient's dignity, to his comfort, or the support during someone's life and the subsequent challenging times. Today, we're very thrilled to have a specialist in this field with us, whose insight and expertise we're going to benefit a lot. So I want to first of all welcome Dr. Karl Lorenz, who is a leading expert in end-of-life and palliative care medicine. Dr. Karl, welcome.
Thank you. It's a great pleasure to be with you.
Just a brief intro on Dr. Karl Lorenz. He's not only an internal medicine physician, but also a palliative care specialist. He's the chief at the VA Palo Alto Standard Palliative Care Program. Formerly lived in LA. Dr. Lorenz directed palliative care research at the VA for innovation and implementation, and served as the faculty at the UCLA School of Medicine. He's a member of the VA National Hospice and Palliative Care Program. He's also the director of Operational Palliative Care Quality Improvement Program and adjunct faculty staff member at RAND. So we've got a fantastic and a very well qualified person for the topic that we have today. The media team is going to play first a brief intro on end-of-life issues to get ourselves started, Dr. Karl, and then we'll take up the discussion from there.
Sounds
Finding
great.
out that somebody you care about is going to die can be very difficult. Even if you've been expecting the news, having somebody actually speak it out loud can have a devastating impact. Life as a carer can be extremely rewarding, but also both emotionally and physically exhausting. And there are very few of us who are able to get through such difficult times without the support of friends or family, or from healthcare professionals who can be with us as we travel the road. Carers can take comfort from knowing that others have travelled this same road, and that while each family and individual is unique, your healthcare team can provide really useful information from their training and their experience of having travelled with others. Watching somebody that you love approach the end of their lives raises all sorts of questions. Are they suffering? What can I do to help? Can they still hear me? Are they starving? What's going to happen next? Having somebody who can help you find answers to these questions can bring real comfort as you do your best to care for your loved one. Even when your loved one appears to be sleeping or resting, they still are often able to hear you or be aware of your presence. Holding their hand, reading to them, talking about happier days and happier times, or playing their favorite music may be comforting for both of you. If you're caring for your loved one at home, you will have the support normally of your own family doctor, GP, and your community nurse. Other health professionals may also be involved in trying to support you, such as the social worker or the specialist community palliative care team. These people will aim to respect the wishes of your loved one regarding their treatment and care, but also to respect your needs throughout your caring work. They will continue to be there for you after your loved one has died, to provide practical information and ongoing emotional support.
So fantastic! I think that is a brilliant little video that set the stage for Karl to come in, and we see this in the hospital, which is the most frequent setting, and sometimes it can be as an outpatient, which is in a nursing home, where you're seeing, we as physicians see that, boy, this is the end of the road for this patient. We've done what we could do, and there is a next step. And the next step is, as a physician, we want to say, what is that we can do now for the patient? Karl, how do you go about in the room and start that conversation, which I know a lot of times you're put in the hot seat and say, hey, the nurse is going to say, it's over to you. We know this is the end of road for the patient. So give us your insight as what would be the best way, and how do you go about in starting that conversation that death is now imminent?
Yeah, thank you for that question. I think, first of all, we want to start with what the patient and the family understand themselves. And so knowing whether they understand their disease, its implications for their prognosis, what they're likely to experience from that illness, and what the care plan currently is really an important place to start. I think another really important understanding to have is the perspective of the patient with regard to wanting to know more information, and the sense of autonomy that they may have and wish to involve their family and other loved ones in the choices that they make. Often we're providing information. We hope that our clinical partners in whatever setting we're in have already started that process. And when we're sharing difficult news for the first time, we really want to have those other important persons there and not provide too much information, because that news can be very difficult to absorb. But building a relationship with the family, recognizing that we're going to be an advocate for them, that we're not an advocate for some other external party, and that really trying to understand what their values are is our goal, is an important starting place for those conversations.
Karl? That's I think a brilliant answer. Why? Because I think you've gone in and you're assessing what does the family know first, and you're also looking at what their expectations are, and you start sort of like an expectation dialogue, and then understand that do they understand that this is the final moments or the final um, the essentially the final times that they're gonna have to have their loved one go, and developing that relationship like you said and giving that information out in little bits sort of sets tone that we're gonna address this one by one. Let me come roll back and say where if we are in a situation, hopefully a lot of times when we are going in, the nurses, the other medical staff are helping us out and giving that information to the patient family and making sure that they all agree with which course the patient is going. Tell us a little bit
I
about
I
what,
real
please go on.
Oh no, I was going to say I strongly agree with, and I really appreciate the fact that you mentioned the nurses. I mean, one thing that's true about our team and about the ICU team or whatever other team we're dealing with is that our visits are episodic, but the nurses are there 24/7, and often they're the ones who are really partnering with the patient and family closely. And yet they're often disempowered in these conversations. So we always want to present the nurses as part of the team. And we often, with palliative care service, we'll have a chaplain, we'll have a social worker, um, maybe trainees with us. So we want to be there with the ICU team, um, with the team that's going to our team that's going to represent itself to the patient, but also to with nurses, the nurses and the nurses who've been at the bedside, really seeing the patient through that part of the journey so far.
Excellent. And I just want to clarify this to the audience here as well. I know you guys are writing, yes, it's a very tough situation, but know that the team that is going in is it's also tough for the doctors to and the nurses and everyone else to break that news. And Dr. Carl is pointing out that they go with a social worker and a religious scholar, the chaplains being there to make sure that the spiritual needs of the family and their religious beliefs are addressed appropriately. And that's also a very important aspect of why everyone is going in this discussion. And a lot of times when we are making that decision, it's really a family, it's a lot of the medical doctors, and we're making that decision as a unit, and it's not just a doctor's call or an ICU person's call, but it's actually a combined effort on trying to address all concerns one have. It brings about an interesting conversation because a lot of times, or some of the times, the discussion can become very abstract and can go haywire, especially when there is conflict in the family. I.e., one party thinks that more should be done, whereas the other party thinks no, less is better. We know this is the end. Carl, give us an example. How would you go about addressing that issue when you have an older son and a younger daughter, or an older daughter and an aunt who right in front of you are like disagreeing that no, this is not what we want to do, and we want to go about it, continue pursuing what we want, and we don't want you to stop medical treatment.
Yeah, that's a very difficult situation, and I think it um, gets back to the point that we always start with the patient, and the patient needs to make an important decision at some point, which is really how they're going to be represented by others, who's going to help them make those decisions and arrange for the care that might be necessary. Um, so I think, what we always try to do is really help everyone understand the voice of the patient. Um, we also want to listen to everyone's perspective. I think a lot of times that situation may arise when someone who hasn't been involved in the individual's life comes from a distance. Maybe a child's been living overseas or is somehow disconnected from the situation. So information definitely is part of what we provide, but our role is always to support the patient and to support the patient's perspective, and that's going to be our starting point in trying to resolve that difficulty.
Thank you for that answer, Carl. And what what Dr. Carl, in a summary, and I think brilliantly pointed out, is that the conflict is there because one family is closer to the patient than the other, and then maybe some other situations. But a lot of time, the people coming from outside, even though they're close but not close to the person, to the patient itself, don't understand what the patient would have wanted. And a common scenario that we put into to the family is that, I know your loved one is dying. We have the patient on a tube. He's got a ventilator. He's got a fluids running. But you gotta think that if XYZ, she or he was in the room, what would have she said or he said about her care? Would she have wanted to go through what the patient is going through right now, Carl? And that's a very common way of how we put our case to make sure that we understand the patient's, the family's expectations. And like you said, we are an advocate of the patient, not an advocate of death, so as to speak.
Right. The other thing to realize is that we all have to grieve, and I think a lot of times that resistance, which can come from us when we're ill ourselves, when we're the patient, but it also comes from the family members, or and sometimes it's expressed in ways that maybe don't reveal the underlying grief, but often that resistance is really because it's so hard for us to see what is right in front of us, which is losing someone that we really care about and love. And so respecting those emotions, giving people a place to grieve, is an important part of resolving those roadblocks.
Brilliant. Brilliant. You brought up another brilliant point, because, we, a lot of times we think that grieving, crying, or being sad is not a sign of a strong human. And whereas you're saying it's a very natural phenomena. And as doctors, and and as people who are with those ones, some can handle that more strongly than others. Is that correct?
I think that's correct. Yes, we all have different capacities.
Very good. One of the questions that has come up is that, how do you make the family, help them emotionally understand that the grief part or the depression part is now here? Do you yourself get involved, or do you ask the chaplain, religious, or social worker to help you out with that? Is that a part of
We
you
work
being?
as a team, and I think it really depends. I think teams manage these these difficulties in different ways. Um, I've worked in the past with, for example, a social worker who um, was just such an incredible communicator with the family, and would sit for long periods of time to work through these kinds of difficulties and emotions. Um, and so it's never one of our jobs. And I think sometimes the physicians on the team, on a palliative care team, may be more involved in making some decisions about symptom management and relief. Um, and it may be in some of those cases that our social worker or our chaplain has really an incredible relationship with some of those family members. So the bottom line is we do it together, and it's really crucial that we have different skill sets, and that we have different backgrounds, because our patients are diverse, diverse in the cultures that they come from, diverse in their religious perspectives, in the illnesses and experiences of illness that they have, and so we really need teams that reflect some of those perspectives.
Brilliant, Carl. Brilliant. Why? Because you brought another point in, and that's diversity, and how we come across cultures that probably sometimes you've never heard of, and people from abroad, especially when they come in and they're sick, and then you're very sensitive towards their feelings, but yet you could be doing the right thing and it could be very wrong, and the wrong thing could be right. Not to mention where our intentions are always good, but being sensitive to their beliefs, whether you agree with them or not, is very essential.
Mm-hmm.
And then the second part you brought in is how the build relationships. If there's already someone from your palliative team have gone about and discussing and has a rapport with the family, that's very instrumental. And a lot of times the family do want to see someone who can speak their language well, who can speak and be sensitive towards, and already have a rapport with the family in that way. They're sensitive. That I want to tell the audience that's something that we are also very mindful of when we are going in and seeing patients, and that's very an essential part of how we go about addressing the end of life issues and stuff. Emotional support is a critical part.
Yeah, and I would add too that we think of the chaplain's job in the hospital as a professional task, but a lot of us have relationships with spiritual communities, religious communities that are outside of the hospital, where we might have long-standing relationships. So one of the things that I like to emphasize is including those individuals in conversations, and bringing them in to also be part of the ministry that we provide to families. So that's another thing to keep in mind. When we're in that phase of life of extreme vulnerability, we need to be able to draw on the resources that are valuable to us, and the healthcare team does its best to represent those, but I think we also may have relationships or other people that need to be part of those conversations in that journey with us.
Okay. Excellent call. I'm gonna let questions come in. There are quite a few of them, and I'm gonna try to sort of like address them in our rhythm. Jeremy wants to play the palliative care, so we'll just give an intro to that, so we can sort of touch on that topic, and then get the expert's view on palliative medicine. Jeremy.
Just hearing the words palliative care can be scary. When a doctor says the person you're caring for would be helped by palliative care, you might think that means they'll pass away soon, but that isn't always the case. In this video, we're going to talk about what palliative care means and how it can help the person you're caring for. Palliative care is a special plan of care that is meant to relieve pain, provide comfort and dignity, and improve the quality of life of the person you're caring for. This special care plan is put in place when a person has been diagnosed with an illness that is life-limiting or terminal, but it doesn't mean that they are actively dying. Palliative care can be added to a treatment plan when someone is in the early stages of an illness and is still receiving treatment to help or cure the illness they have. Being diagnosed with a terminal illness affects the lives of the person with the diagnosis and their caregivers, family, and friends. Palliative care is meant to help with the physical parts of their illness, as well as help with the emotional, spiritual, social, and cultural needs of each person and their family. There are 4 main goals of palliative care. Number 1 is pain control. Doctors, nurses, and pharmacists will work together with you and the person you're caring for to come up with the best plan to make sure they're not in pain. Number 2 is managing other symptoms of their illness. This can include nausea, vomiting, loss of appetite, having a hard time breathing, or confusion. Other healthcare team members like dietitians or respiratory therapists may also help with the care plan here. Number 3 is helping make sure that the person you're caring for and their family, friends, and caregivers' emotional needs are met. This can include speaking with a therapist or a religious or spiritual leader. Number 4 is support for you as their caregiver. Helping care for someone through a terminal illness can be all-encompassing and really overwhelming. You'll need support. Palliative care services can help get you home care support, training on how to do things like give medications or changing a wound dressing, or access to volunteer relief programs so that you can go out and get groceries, take a bath, read a book, and know the person you're caring for will be supported when you take a much-needed break. Having palliative care services will help make sure that they are supported completely, which helps reduce worry, stress, and fear. For more information on topics that support caregivers,
So that Carl, sets the stage for palliative medicine. I'm going to ask you to just give us your perspective, just an intro brief about palliative medicine from your eyes. How do you see it? We know that it's exploded in the last decade or so, especially in the U.S. But what's your view and perspective? We'd love to hear that.
Yeah, well, one thing I had a brilliant social worker, like I mentioned, that I used to work with, and I remember she always said to patients when she was trying to explain what is palliative care, it's an extra layer of support. And I really do think about it that way. Our task is often to figure out what the patient's needs are, how to control their symptoms in a way that helps them live as well as they can, and maybe adapt to their new situation. And so an extra layer of support is a good way to think about it. I think, it's challenging depending upon the disease that a patient and family are living with. That period of challenge can stretch over years. And in some cases, of course, things could be very short, or this kind of difficult news could be very precipitous. But in conditions like dementia, the challenges of understanding a person's perspective and their wishes for treatment and of managing decline can really be a challenge for several years. And 2/3 of us will have difficulty with basic functional challenges in our home environment for 1 to 2 years before we actually die. And so palliative care gets involved at different times in those journeys for people, but the struggle can be a very long one, or maybe a challenge that's pretty short, just depending upon what the illness is.
So let me ask a few of the questions that have come about. When would you say is the time someone should get palliative care support?
That's a great question, and I feel like some of the issues, like outlining who should be involved in a conversation when you're very sick and can't take care of yourself, or can't speak for yourself, rather. Those conversations are ones that the doctor's taking care of you over those years of living with an illness should be attending to. That's not anything that necessarily requires a palliative care specialist. I think also understanding a person's basic values and goals is not necessarily the task of a specialist consultant. We do tend to get involved when those conversations are really difficult for people. The situation you mentioned where family members don't agree, or whether there are other sorts of challenges, like a person doesn't have someone to represent them, but they also are incapacitated. So we tend to get involved in maybe hospital settings more often, or conversations that require more expertise. But basic parts of it should be attended to by your oncologist, or your pulmonologist, or the nephrologist who's caring for you on dialysis. Those sorts of clinicians, as you know, often are caring for patients who have really challenging prognoses, maybe not in the very short term, but really have significant underlying conditions with symptoms, and so the basic discussions should not be delayed. I think we tend to get involved in hospital cases before patients go to hospice. So that's a common situation when there are challenging symptoms associated with conditions of poor prognosis. So cancer pain is a classic example. Shortness of breath in patients with significant lung disease or heart failure. Uh, so so challenging symptoms, challenging conversations, transitions that are going to occur. Patient may need a transition in the treatment home. Those are situations where we are almost certainly going to be involved, especially in the hospital setting.
My dad is a question. My dad does not have cancer, but he is debilitated, and I'm not able to look after him now. Should I consult palliative care medicine?
Wow. I think the first thing you want to have is a great primary care doctor, and I it's hard to answer this question in a generic way. I think also when we're older, those years where we're challenged maybe by multimorbidity, by multiple conditions, um, someone with skills in caring for aging adults is also really important. I think that depending upon the underlying conditions and the real prognosis, that your father would be facing, I think palliative care can help. And particularly if you feel like some of those things we talked about aren't getting done, like having a conversation about a person's goals and making sure that they're known, managing symptoms. I have to say, many health systems today do have access to outpatient palliative care, and that might be where your needs would be addressed. The other kind of care that would be really helpful would be home-based palliative care, and so especially when a person is particularly frail, that might be an option. So it can be delivered in different settings, and depending upon um, what your dad is specifically facing, I think there are a range of physicians who might have an important voice in his care. I think palliative care could contribute, and possibly in different ways. So I'd want to know a little bit more about that to give you specific advice, but I think the answer could very well be yes.
Yes, I think I agree with you. I think there's just the questions rolling in. So, but let me ask. I think you've answered it quite brilliantly. Let me ask you a next question, which has come asked me repeatedly now. Uh, my family member has cancer, and at times she gets better, and at times she's worse. I am really confused, doctor. When should I trigger the hospice button and make sure and have that as a part of my treatment? So I think what she's trying to say is hospice is there. Would you explain a little bit about hospice? When would that be? When should that be triggered and be part? Because that is really considered an end of life event or an end of life package.
Mhm. Yeah, so hospice is a particular type of service that provides care mostly at home, although hospice does have other things like respite when the caregiver needs a break, and there are inpatient facilities for hospice when a person requires care that is too complicated to provide just in the home. Um, I think hospice is a decision, a type of care and support that people elect when they really recognize that death is coming in a space of what is typically months. Um, so, so in those situations, it's true that sometimes you can still have waxing and waning, and I think the most important thing is a person's preferences and their perspective on their own health and goals for life. I think when uh, some of us get to the point where returning to the hospital, we've been there so much. Maybe that's just not something we want to do again. Um, and and I think especially when we're not particularly looking for that kind of intensive support, the kind of care we get in a hospital, and we're also living with an illness that we know well, or a constellation of conditions that we know well, is limiting our life to some months perhaps. Um, then hospice is really a wonderful choice and a wonderful way to get support.
You've
Is that
explained it. Yeah. Sorry, please keep going. Yeah.
could I explain what?
Yeah, please. I was just saying, sorry, I interrupted you. You were going to finish your sentence. If you have a sentence, call. Otherwise, I can ask the next question.
Oh no, you can ask the next question.
Yeah, so it's just the next bit on it, and I want to tell all the audience here, what Dr. Karl is saying, you have to really factor in the patient's preference. And sometimes we get so emotionally involved that we are putting our preferences in, forgetting that the patient is in pain. The patient is suffering. And you have to factor that in, and that will probably make your decision easier about when is hospice, when is not hospice. And it's very, very tough because I can't imagine making a decision of my loved one without factoring in my emotion, because we're trained or entrained in that way. When it comes to my family member and stuff, we all get it very confused and messed up when it's that. But a good way of looking at it is, what is the patient want? And then you sort of like discuss it with your physician, so you get a consensus on what needs to be done about it, and then make a decision. And I want to just say to someone's answer, yes, these discussions are the most painful discussions ever. You don't want to think about them. And the reason why we brought in an expert in this field to try to tease out these conversations, which Dr. Karl has brilliantly assembled for you guys, is that when you're going to come across this hurdle, or you're going through this hurdle, you are making a good decision on this. So just to let Karl know that a lot of people being appreciative, but also saying it's a very painful topic. Even just some people don't even want to think about it until it's hit them. But that's honestly not a smart approach. You have to, in your mind, have a approach or a program how you're going to address that, because at that time it becomes very hard to make any decision. So just to let you guys know, and just to let the audience know, that that's part of it, part of the process that we're trying to address here. Okay, that's where palliation, end of life came in, palliative medicine comes in, how we're going to address the needs, and hospice comes in. So sort of like all entangled with each other. Palliative medicine, Karl, has come up in a few little. One of the discussions or topics, questions that has been put forward is, what are the changes that you are seeing, or upcoming changes in the field, and how do you see that this will change in the next 10 years, or especially in the age of AI?
Yeah. Well, one issue is I think we're a little better at understanding risk. There are ways to identify risk in advance from information we get about a person's overall health. And so whether that's in the context of having a surgery, or just when you're under care. I think many times your healthcare system will have an idea of the risk you face for end of life, and that's really not something that should be kept from you. It's something that I think we all need to understand when that information is already in the hands of the people who care for us, or the system of care that we're part of. So that theoretically is helpful, right? In both in addressing healthcare problems that are reversible, but also coming to terms with the need to bring our affairs in order. I think the other part of care that's changed is the use of telehealth. And while this has been a phenomenon across medicine in general, especially after COVID, it's increasingly an important part of caring for us when we're frail, because we face very limiting circumstances, as I've already mentioned, and so telecare or telehealth is really important, as is home-based care. And I think the other part we've also touched on, which is diversity in medicine. And I don't, I think that's just an increasing need for us to be responsive to changes uh, in American society, in particular, in who is represented both in our healthcare workforce, but also in the diversity of patients we care for. I, having read a little bit about Islam and understanding the perspective of Muslim patients and families to a degree, I really feel like it's important to be an advocate for yourself too, to let your providers know what needs you have. And one of the things that's really important for providers to recognize is that every person comes to these places in life on our own terms. So it's important to recognize commonalities and aspects of one's faith or religion, but also to recognize that we all are individuals and need to be respected as such. I think the role that I really value in the patient and the family is when people will speak up for themselves and share what they need and be cooperative and collaborative with us in helping us obtain it for them. So um, yeah, those are sort of three issues that I think are really important, um, and also, are changing the way we practice and think about palliative medicine.
You've sort of brilliantly summarized it. I think again, once again, it's just your answers are very on the dot. And whether the beliefs are you're from a Muslim background, Christian or Jew background, we are always sensitive, and you build that rapport relationship with the family, and we always as physicians keep that at the back of our minds, how how we're gonna navigate, and you're gonna make the decisions. But at the end of the day, the point you brought about is you have to be, the patient has to be, or the family has to be an advocate for themselves about how they're going to bring about that change, or how they're going to bring about that plan of action. So really appreciate that comment, which sort of like helps a lot. Um, I know we're running out of time, and I just want to address one or two little questions. One of them is, Dr. Karl, what's your thoughts about places which don't have setups of palliative medicine well? And there may be because there are no setups or resources are not well. You brought about the telemedicine aspect of it. What do you think about different groups, support groups that help people navigate situations emotionally, i.e., Facebook groups or other groups like that? And what's your thoughts on that? And does that play any help or role?
Yeah, I think it's hard. When you're dealing with an elderly family member, or yourself are elderly, or when you're dealing with someone who has a significant illness, recognizing that this is going to be part of the care that you may value, and also may be important to feeling well, or as well as you can. That's something you need to realize at the outset, and I think it's something you should expect these days from healthcare providers and healthcare systems. I it very much depends upon where you live and what kind of care you have access to. I know in small independent practices, someone may have all kinds of good intentions, but not really be able to connect you to this kind of care. Um, and and I think physicians in those settings are really challenged. So knowing that you need it is really an important place to start. I I think most communities these days do have some resources in this regard, and um, there is some flexibility in the settings and ways in which it's provided. So um, you can go on websites like the Center to Advance Palliative Care, and I think you can sort of find a directory which can help steer you to some of these resources. I think organizations like the Alzheimer's Association also these days have some information about these kinds of services and care. So I think the first step is to be aware, and the second step is to look for it. But um, I don't have particular advice about social media.
Fair, fair
I
enough.
I think that's just a fault of my own because I'm not much of a user. But yeah, I would look widely, um, and I would have high expectations.
Excellent.
And I think that's the best advice I can
I know
give.
that's brilliant. I think if you're
Um,
not aware and you're not sure, one thing you pointed out, which is very good, is that you need to make sure that the expertise exists and the person who's giving you the advice is the right advice. And sometimes in the groups, it can be a little bit tedious. It can go wrong, and people have misconceptions here. I'm just gonna take two questions, and we're almost done for the hour. If I have Dr. Sophia, if you have questions, you can hear us. Is Sophia on? Okay, Sophia, if you got the mic, please, Dr.
Yes,
Karl.
sir. Sir, can you hear me?
Yes, we can.
First of all, I would like to thank Dr. Kaul for such an informative session today. It was very eye-opening for everybody. So we have discussed about how we have to deal with the patients and their families. I think that when we are providing palliative and end-of-life care, it can be very emotionally taxing for the healthcare providers. So I would like to ask Dr. Kaul that what strategies can we use to take care of ourselves when we are providing care to the patients, and what steps can we take as a team, the doctors, the nurses, what can they do to help themselves to help the patients around them?
Yeah, I mean, I think the first thing is um, something that you are really acknowledging here, which is mutual acknowledgement of the challenge, the emotional challenge. Realizing too that not only do we have maybe the emotional burden of the work, but we also experience these things in our own lives, and sometimes we don't. We need to take the time to acknowledge illness in our own families, responsibilities we have for caregiving at home. So you know, uh, developing a team where we have that sort of transparency is really important because then we can care for each other as well as we care for the patients we're responsible for. And I think also teams deal with this in different ways, including having regular uh, decompression or chances to kind of talk about the challenges of the week, sometimes moderated by somebody with some skills and responsibility in that area. Um, our own programs, we have a wellness coordinator who I think takes that on as a responsibility. Um, and depending upon the size of the team, that can be a possibility. Uh, and so it's a it's not a there's not an easy one size fits all answer because all of us recharge in different ways. We all need sometimes some space away. We all need time to process and have the opportunity to elicit our experiences and discuss them. And we all need time to take care of these needs when they arise for us in our own lives. So I don't know. Those are some of the ingredients. They can be applied in different ways. There's certainly different programs that can help teams with this, but it sort of starts from that basis, I think.
I think that's wonderful. Caregivers should not forget that their health is also important and they got to look after themselves. Let's take the last question from Rida because we hit over almost an hour already, and then we'll try to sum up the rest. And Rida, if you can hear us, we'll love to hear your question.
Yes, I can hear you. Hi, Dr. Karl. Thank you for coming on the show. We really appreciate your expertise. You
Thank
mentioned palliative care for dementia patients. My uncle had dementia, and there was a lot of pushback from him when receiving his treatments. With that sort of person who is fighting back against treatment but can't really articulate their displeasure in any other way besides physical breakdowns and everything. So they're giving that pushback. Do we still go forward with the palliative care even if the patient doesn't want it and aren't in the right state of mind to deny it? What do we do in that sort of situation?
Well, I think one thing, I try to approach resistance to these issues by acknowledging that we hope things are going to turn out as well as possible too, whether that's the patient or the family that might express that resistance or misgiving. Realizing that we're not here to extinguish hope, we're here to support hope, and uh, and we can even hope for a miracle as long as we deal with what we're facing today. And so I don't. I think knowing more about that resistance is really important. Realizing too um, that we value life, and just really our goal is to help people live it as well as possible. And dementia is a long-lived condition. Um, if we don't address patients' goals early on in their course of illness, we'll never know what they are, because by the time some of the more critical issues arrive, like feeding tube use or repeated hospitalization, nursing home residents, patients may not be able to speak for themselves. So we really have to find ways to have those conversations early. Um, some of the other care may be delayed though for a long time, and um, so doing this in the context of not necessarily even palliative care, but also under the care of a geriatrician or when a person is in a primary care setting is important. Um, I think that resistance can arise at any point in care, but by the time a patient is really ill and facing some of these more fraught decisions, it's usually the family that's really confronting those issues. And I would say always acknowledging when a person is even very, very sick, even when they're actually not responding at all. And I say this in intensive care settings and other settings, but always respecting the individual as a person, always treating them as someone who is present and part of the activities and conversations, even if they're not actually responding. And so that's also part of, I think, of the challenge that we face in this kind of care is devaluing individuals as their capacity wanes. And that can also help, I think, for individuals, for family members to recognize that it's not about shepherding patients just into death. It's also providing them with the best possible life, the respect and dignity that they deserve, no matter where they are in the journey.
Excellent. Dr. Karl Lorenz, I think we've had such a brilliant session, and there's so many more questions I have, and unfortunately, I don't have the time. But I personally want to thank you very much from us, for the team members and everyone. It was a great presence and a great show, so we really appreciate it.
It was truly my pleasure, and thank you so much for raising these issues with your audience and allowing folks the chance to learn a little bit more about the challenge that we all face.
Thank you very much. Thank you again. Well, our next segment is going to be about discussing some of the previous events that we have done. And I want to just go about firstly congratulating the team members for the USA webinar that we've had last week. A lot of efforts went in, A lot of team members have helped out. So let me just start by acknowledging a few of them. We have Dr. Sophia Avan up first. So thank you very much. Everyone did a brilliant job, but so have these members. Sophia Avan is first. We have then Dr. Vijaya Kiranavan, brilliant, talked about insomnia. Thank you very much. That was brilliant. Dr. Jannat Malik did a brilliant presentation as well. Very nice. Dr. Fatma Tuzora helped Sophia. Both of them worked as an excellent team and a great presentation as well. Akif Bhai did a tremendous job. Akif, well done. Akif Saleem did a brilliant job. Mary Lee Bukowski and excellent talk about kids, did the intro on it. Thank you for doing that. Ryan Brewer presented with Jannah and did a marvelous job as well. Thank you, Ryan. And of course, Dr. Hamza Sana was the chief architect and helped coordinated, facilitated, and made sure this show was presented brilliantly. So thanks, Dr. Hamza. And lastly, Brenda Weyrick. She presented the kids session on sleep, and that was marvelous as well. Besides that, I want to acknowledge and make sure that mention Rida Rauf, who behind the scenes, as a lot of the doctors know, was one of the chief architects of it. So Rida, thank you very much for doing that. And just bringing about that effort and coordinating that and presenting it to other people was very, very brilliant. And then Maliha did a fabulous job. Along with Sabah, I want to mention, they both coordinated and did an excellent job. And then the social media team, Hafsa Farzana, did a sort of like brilliant job as well. I want to acknowledge them as well. And then don't forget in our studios how CU and Jeremy did a brilliant job as well. So Jeremy, we haven't forgotten you. You did a really smooth presentation. And Jeremy had to be woken up 5 in the morning, and CU made sure that he's woken up, so we didn't have to throw stones on his window to wake him up. Right, Jeremy? You woke up yourself 5 in the morning to get that show here for the people live. We had a standby plan. If Jeremy doesn't wake up, CU had big stones ready and she was going to throw it at the window. So she knew where Jeremy was sleeping and the spot she was going to hit 5 in the morning. Right? Is that right, Jeremy? Yeah. So really nice. Okay, we had that planned out. All right. And so after that, we want to say we'll be discussing next week, likely Dr. Inza was going to be discussing about another PCOS issue and a common sort of a gynecological issue, a women issue. We want to bring about a little bit of awareness on that. And so we have that. That's going to be next Friday, same time. So we'll have you guys come then. Other than that, thank you very much for being patient, everyone, and joining us. I see a few of you are missing today, but hopefully we'll have everyone back next week. Thank you very much. Have a blessed weekend. And it's bye from here from the studio. Unmute. All right, Rida.